Dr. Peter Birks and Dr. Mohammud Atiquzzman. Dr. Birks is a practicing nephrologist in the Fraser Health Authority, as well as having done his nephrology at UBC and obtained a Master's of Health Administration at UBC. He is a clinical assistant professor at UBC in the Division of Nephrology and has been an active part of our research group over that time. Dr. Mohammud Atiquzzman is a PhD research scientist with BC Renal, has a PhD in pharmacoepidemiology from UBC, has worked in a number of different places, including New Zealand, and we're thrilled to have him as part of the division and the BC Renal family as a research scientist to help us understand and manage patients better through thoughtful analyses and project work. So with that, I'm going to hand it over to my colleagues to give us an update on some of the programs of work that have been going on. Over to you.
Thank you, Dr. Levin, for the nice introduction. So I'll start sharing the slide.
All right, so I'll kick it off. Thanks everyone for having us today. We'll go through some objectives of today's talk. I don't know if you guys have heard of this COVID thing that happened, maybe one or two talks on it or one or two Zoom calls over the past several years. But now that we're sort of approaching some degree of normality, we wanted to talk about some of the work that we've done in our CKD population surrounding COVID. So we'll start with a bit of an intro and then review some of the vaccine data. How did we do in BC and vaccine effectiveness? We'll look at renal outcomes, both in patients with and without CKD. And then at the end, we'll switch gears to some new ways of risk stratifying CKD patients in BC, not only those who have had COVID. So it's been more than 3 years since the WHO declared the COVID-19 pandemic. And it's been since October 9th, 2020 that Health Canada received Pfizer's submission, and then very quickly in December authorized its use. And the first doses were available in BC that month. So we're going to talk about how we did with vaccination in our CKD population in BC, because there's not any previous data on this. And there's minimal data in CKD populations in general. And what do we know about vaccine effectiveness in our kidney disease patients? A little bit of introduction on COVID and kidney disease. I know you guys have heard a lot of this already, but kidney disease is people with COVID who are found to have kidney disease on admission. That's associated with increased mortality. In patients hospitalized with COVID and AKI, about 46% of those patients had acute kidney disease at the time of discharge. So AKD is that sort of in between AKI and CKD, but you know, that's 7 to 90 days of abnormal kidney function or structure. And COVID is an independent predictor of AKI in hospitalized patients, even when controlled for other factors like severity of illness, demographics, meds, etc. In patients who are admitted to the ICU with COVID and AKI, about 81% of them had renal recovery at hospital discharge in one cohort, about 90% at 90 days. But if you look at either low kidney function or structure 90 days later, 16%, so pretty high proportion, were left with incident CKD and all of the issues that come with that down the road. In terms of, if you can go back, AKI trajectory in CKD, one cohort looking at hospitalized patients with AKI, so all patients with AKI, COVID or not COVID. Those with COVID had a more rapid decline in eGFR after discharge when you compared their discharge creatinine to their first outpatient creatinine. And those who recovered, they recovered more slowly when their AKI was in the context of COVID. There's a number of ways COVID can affect the kidney. So the most common cause of AKI is ATN, but it can cause rhabdo, microthrombosis, which can cause acute and chronic issues. In some of the case series where they collected biopsies, there were interstitial disease and glomerular disease seen. There can be direct viral infection of kidney cells related to the angiotensin II receptor, and all of these things can lead to downstream fibrosis. So what are some of our unanswered questions that we want to sort of talk about today? So in those without CKD, what's the risk of downstream kidney disease in those following COVID-19 infections? And we have a cohort from our post-COVID clinics that includes hospitalized patients and long COVID patients. And in those with kidney disease who were followed by nephrologists in BC, what's the association of COVID infection with CKD progression? So why are we well equipped in BC to answer these questions? We did have our post-COVID interdisciplinary care network throughout the province, which was unique to BC. We had multiple COVID recovery clinics that followed patients post-hospitalization and those with long COVID in our province in a standardized fashion. And we have Promise, which has both our kidney disease patients followed by nephrology who are in Promise, as well as our post-COVID clinic patients actually are all in Promise as well. Bit of a spoiler, we will show data that people who did not have kidney disease previously did have an increased risk of downstream kidney disease, renal decline, and proteinuria. We'll also show that those with CKD are at an increased risk of progression following COVID. And then, as we said at the end, we'll switch gears to talk about new ways to risk stratify CKD patients in BC. So I'll send it over to Atiq to talk about the vaccine data.
Thanks, Peter. Can you hear me now? Okay. It's my pleasure to present our research here today. So the first project I will be presenting is estimating the vaccine effectiveness in CKD patients in British Columbia. So first of all, why we needed to estimate the vaccine effectiveness in this population. So in the RCTs that estimated the COVID-19 vaccine effectiveness in general population, only 1% of the study sample had renal disease, and both the RCTs excluded patients who were on immunosuppressive medications. And the sample size of this subgroup was low, and the vaccine effectiveness was not reported for this subgroup of population. So the vaccine effectiveness in CKD patient was unknown then. This is the interim guideline published by WHO in early 2021, urging for evaluating the real-world performance of vaccine effectiveness in subgroup of population. From the previous knowledge, we know that CKD patient has a lower response against other vaccines. So it was important to estimate the COVID-19 vaccine effectiveness in the CKD population. So we conducted a retrospective cohort study using Promise data. Our study span was 1 year, just immediately after the vaccine was first available in BC until the end of 2021. We modeled the vaccine exposure as a time-dependent variable. What it means that a patient can change their exposure over time. So starting as an unvaccinated person and then exposed to one dose, gradually going over to second dose and third dose. So the reference is always the pre-vaccination person time that estimate vaccine effectiveness against one dose compared to pre-vaccination person time, 2 dose against pre-vaccination person time, and so on. And we studied 2 major outcomes. One is the incident COVID-19 infection determined by RT-PCR. And second was the COVID-19 related severe outcome defined by hospitalization or death. So this was the first study that reported the COVID-19 vaccine effectiveness in this non-dialysis dependent CKD patient. It was published in Kidney International in September 2022. So let's go over the result. Our study sample included a huge number, close to 19,000 patients. Median age was 74 years, approximately 53% was male. We are seeing here the dosing distribution. So after the cohort entry, the median time between the first dose was 110 days. The median time between dose 1 and dose 2 was 75 days, which was much higher compared to the recommended 21 days. And between second dose and third dose was approximately 5.5 months wait time. And we had a median of 38 days follow-up time after third dose. So with this 1 year follow-up period, we are able to measure the vaccine effectiveness against all 3 doses. This is the outcome distribution in our population. In general, our British Columbia province did very well. Out of this 19,000 patients, only 454 patients developed the outcome. Approximately 87% of the population, study population, received at least 1 dose, of which by the time the study ended, only 5% were at 1 dose. 37% patient received fully vaccinated with 2 doses, and 58% of the study sample received 3 doses. And 268 outcomes were attributable to the pre-vaccination person time, and we had sufficient number of outcome in all 3 doses time period to estimate the vaccine effectiveness. This is the most important part, I believe. How did the vaccine did in the CKD population? The solid red line shows the hazard ratio of 1, that is no effect, which is the pre-vaccination person type, our reference. Vaccination with 1 dose was 59% effective in preventing COVID-19 incident infection. Fully vaccination with 2 doses was 71% effective, and a booster dose with 3rd dose was 78% effective. I would like to mention here the dotted line we see here on the left is the efficacy reported in general population. So what we see is vaccines, COVID-19 vaccines were highly effective in preventing infection in CKD population, but the effectiveness was lower compared to the general population, which makes biological plausible. This is the outcome estimates for the effectiveness against severe outcome defined by hospitalization or death. And the same thing, fully vaccination or booster dose was highly effective in preventing hospitalization or death among CKD population. Finally, we stratified our study population by EGFR category of less than 30 or greater than 30. And the finding was counterintuitive, where we found that fully vaccination with 2 doses or a booster dose was more effective in patient with less than 30 ml per minute compared to patient with higher than 30 ml per minute. So to summarize, what we found is COVID-19 vaccine, mostly the mRNA vaccines, 98% of our study population received mRNA vaccines, were highly effective in preventing COVID-19 infection as well as hospitalization and death. And we observed a dose-response relationship in which we found that higher dose gave better protection. So then we moved on to estimating the COVID-19 vaccine effectiveness in maintenance dialysis population. What was known in this field is, I believe this is the first study that estimated the COVID-19 vaccine effectiveness in patient with maintenance dialysis in Canada, published from Toronto. And similar to the non-dialysis dependent CKD patient, 2 dose was 69% effective in preventing infection and 83% effective in preventing hospitalization. What was unknown in this field was if there could be regional variations. Let's say, can we take the vaccine effectiveness measured in Toronto and think it's applicable, Ontario and applicable in British Columbia? Or could the pandemic waves could vary in between provinces, vaccination strategies could vary, and could this have an effect on vaccine effectiveness estimates? So for example, British Columbia province adopted a 4-phase COVID-19 vaccination plan where we prioritized the frontline healthcare workers who were serving COVID-19 patients and residents of long-term care, elderly patients to receive their first dose first. In March 2021, the clinically extremely vulnerable population were prioritized, and patients who were on maintenance dialysis were included in this group. More interestingly, our province of British Columbia extended the interval between first and second dose to get more patients more people vaccinated with first dose first before we starting the second dose. So our objective was to describe the key differences in COVID-19 pandemics in Ontario and BC and Ontario. Then we investigated the COVID-19 vaccine effectiveness in maintenance dialysis patients from British Columbia, Canada, using the similar method as the Ontario study. And then we investigate if the vaccine effectiveness could vary among these provinces. So our study, again, we had just over a 1 year time period, and we included around 4,300 patients who were on maintenance dialysis. Here we see the wave differences in British Columbia and Ontario. The solid red line represents the pandemic waves in British Columbia, and the gray line shows the waves in Ontario. So for the solid line in between, it describes the overlapping period of two studies between Ontario and BC. So the Ontario study ended early for only follow-up for only 6 months, whereas in the BC study, we had approximately 1 year follow-up. So what we clearly see, the time overlapped between Ontario and BC. The Ontario experienced two distinct pandemic waves with much higher infection rate compared to one wave in British Columbia and lower case rate. On the other hand, in the summer 2021, the case rate was higher in British Columbia. If you look into the variant, most of the second dose, when it happened in Ontario, the Delta variant was just gradually increasing from 5 to 36%, whereas in British Columbia, during this higher rate, Delta variant was predominant. It's approximately 91%. So what we see is pandemic waves, the case rate, and the variant was also different between these two provinces. Here we are seeing the vaccination strategies. As I mentioned in my previous slide, that BC had adopted a different vaccination strategy, that we finished the first dose, the maximum number of population, then we gradually start the second dose, and the number of days between dose 1 and dose 2 was extended in British Columbia. So here the orange color shows the dose 1, green color shows the dose 2, and the blue shows the dose 3. If we look into the Ontario, so the dose 1 and dose 2 started much earlier, and it was going along with first dose vaccination. Compared to British Columbia, most of the patients received their first dose first, then there was a long gap between first dose and dose 2, and then there is a second dose happening, the long gap, then we started the third dose. So since our study duration was a little bit different, because we had to extend our BC analysis to capture much outcomes to be able to model the relationship. So vaccine type studied, Ontario included only mRNA vaccines, whereas we included all 3 vaccines approved in British Columbia, including the AstraZeneca. We studied 3 doses versus Ontario studied 2 doses, and the lag time used in vaccine effectiveness exposure. So these are some factors that may contribute to difference in COVID-19 estimates. So if we look into the difference into the study sample, the proportion of Asians were almost double in British Columbia sample compared to Ontario. So it's 17% versus 35%. Diabetes as a comorbidity was substantially higher in BC cohort. We had access to patient level immunosuppressive medication data compared to Ontario data. Follow-up was much higher. 2 dose was 26% patient in BC compared to 74% in Ontario data. And more importantly, timing between first dose and second dose was 77 days in BC compared to only 39 days in Ontario. So now it's the result. The left-hand side table we see is the vaccine effectiveness. So exposure to 2 dose appeared to be much, more effective in BC, 80% versus 69%. although the difference in variation was not statistically significantly different. The same thing for hospitalization or death. Interestingly, for the severe outcome, Ontario, the 2-dose appeared to be more effective in Ontario versus British Columbia. So Danuta published a paper in infectious disease that they reported that extending the time between first dose and second dose increases the effectiveness of mRNA vaccine. That could explain that this signal here that 2-dose was more effective in preventing infection in BC. And Toing et al. Published a paper in Lancet where they found that the hospitalization due to Delta variant was much higher compared to infection to Alpha variant. So if we remember this graph, most of the infection appeared to second dose. The Delta variant was predominant in BC. Most likely that has contributed in this signal, but overall, none of these differences were statistically significantly different. So what we found that there are substantial differences existed in number of pandemic waves, the infection rate, and the vaccination strategy in 2 provinces. However, the COVID-19 vaccine were highly effective in preventing both infection and hospitalization or death in maintenance dialysis preparation patient in both British Columbia and Ontario. The vaccine effectiveness were not statistically significantly different, and we observed a dose response relationship in both provinces. So we could do a future research with a pooled analysis to estimate a nationally representative vaccine effectiveness in Canada. I'll hand over to Peter now.
Okay, thank you. So at this point, we're going to look at some of the outcomes, the renal outcomes in after COVID infection. So either long COVID or post-hospitalization with COVID in terms of renal outcomes in patients in BC who were followed in the COVID clinics. We've already talked about COVID and its effect on the kidney. So in terms of referral into the post-COVID clinics, these were people who had long COVID, so ongoing symptoms or effect on physical function after 3 months. And there is some previous data in the US showing that long COVID patients are at increased risk of kidney outcomes. Okay. This is just the visual abstract for our paper that's been submitted, and I'll go over each part of this. So we investigated the effect of post-acute COVID syndrome or long COVID on kidney function among patients followed in the PCRC or post-COVID recovery clinics in BC. This was a retrospective cohort study. We used the PROMIS data in which all the post-COVID clinic patients data was in PROMIS. We had 5,600 patients referred to the post-COVID clinic between July 2020 and April 2022. Healthcare practitioners could refer any long COVID patient, and there was an automatic referral following hospitalization with COVID, and these were adult patients. All of them were seen in the COVID clinic 3 months following COVID infection or symptom onset. And they had standardized follow-up for multiple investigations, including creatinine and urine ACR, starting at 3 months and ideally going 3, 6, and 12 months. We excluded patients on RRT or those who died within 3 months of cohort entry. So our exposure was COVID-19 infection were confirmed by PCR, or if that wasn't available, epi-linked through public health. Our primary endpoint was the change in eGFR or urine ACR after COVID-19 infection, and we categorized eGFR with the following 6 categories. We also categorized urine ACR based on what's commonly used in CKD. And we used a linear mixed model to account for repeated measurements of eGFR on the same individual, because everyone did get blood work done at 3 months when they came into the clinic. but it was variable who had labs done, prior to that and who had labs done at 6 and 12 months, as some people dropped out of the clinic, didn't do their blood work, were discharged, etc. So there were 5,600 patients referred, and after exclusion criteria, we had a total of 2,202 patients. We did separate into two subgroups, those who had a pre-COVID EGFR recorded in the 6 months prior to infection and those who didn't. And the reason for this is we assumed if a patient had had labs done prior to COVID, they were probably done for a reason if they had creatinine or urine ACR. So some of those patients may have had pre-existing kidney disease or being higher risk patients. So they may be a different group. So we had, as we said, over 2,000 patients, average age of 56, 51% being male and 46% being Caucasian. There was 39% had underlying cardiovascular disease, 35% diabetes, and 47% hypertension. And if you look at those who had pre-COVID EGFR, they did have a higher risk of a higher proportion of these comorbidities, and they were a little bit older. So all the patients had an EGFR at 3 months because that was inclusion criteria, and that's when they were that was their intake time into the clinic. Out of those 2,212, 1,643 had a GFR at the time of COVID infection. The urine ACR numbers were definitely lower. And interestingly, about 77% were unvaccinated, and you can see the proportion of those receiving various numbers of vaccine doses as well. In terms of data availability at the different time points, everyone had EGFR at 3 months, and 1,179 had the pre-existing EGFR between 15 to 183 days before they got COVID. About half the patients who had the data at 3 months also had an EGFR at 6 months, and then 685 had EGFR 12 months later. And the urine ACR numbers can be seen as well. I know this is a busy figure, but this shows the proportion of patients within each EGFR category at the various time points, pre-COVID, time of COVID infection, and 3, 6, and 12 months following COVID. And it includes all patients and those with or without the pre-COVID EGFR. So a few things of interest: about 47 to 50% of the study had a normal EGFR greater than 90 at the various time points following COVID infection. A small number, less than 5%, had EGFR less than 30 across any time point. And the percentage of patients with reduced EGFR was consistently higher amongst the patients who had had pre-COVID renal labs checked throughout the study period. And these are the results from our linear mixed model of the entire study cohort. You'll see along the y-axis through the entire cohort, those with pre and without pre-COVID labs, and then subgroups of hospitalized or non-hospitalized and diabetic or non-diabetic. So in the overall group, there was an average annual change of EGFR loss of 2.96 mils per minute per 1.73 and a meter square. And that was a larger EGFR loss in those who were hospitalized, so minus 5.72, and those with diabetes, minus 5.01, which makes sense. Okay. In terms of the distribution of urine ACR, similar figure that we looked at initially for the GFR. So 36% of patients appeared to have albuminuria post-COVID. And the percentage of patients with moderate to severe proteinuria was higher amongst those who had had pre-COVID labs. So we did look at a subset of patients who had labs done at every time point, 3, 6, and 12 months. And there was 457 patients included there. And we did this sort of as a sensitivity analysis to see whether the findings would be similar to looking at the entire cohort. And essentially, they were very similar and reflective. This is the CKD progression linear mix model of that subgroup that had labs done at each time point. And we had very similar findings of GFR annual loss of 2.81 in the entire group, almost 5 in the hospitalized patients, and just over 5 in the diabetic patients. So very similar to the primary analysis. So we overlaid some of our data onto the CKD heat map in terms of risk of CKD progression. About 60% of patients were low risk initially, and about 57% at 6 and 12 months, but 40% of patients were at increased risk of CKD following COVID. And a smaller amount, less than 10%, were at the very high risk, very high risk group. So in terms of conclusions, people with long COVID or post-COVID hospitalization did have a substantial decline in eGFR within 1 year. So this is much higher than sort of the expected age appropriate loss of eGFR of 1 ml per minute per year. And even in those with diabetes, that loss of just over 5 was higher than what you'd see in some big diabetes cohorts, such as the SGLT2 inhibitor trials, whether it be in the placebo or SGLT2 group. The prevalence of proteinuria was high, and we all know the importance of proteinuria and CKD risk and progression. So close long-term follow-up is prudent in these patients with persistent COVID symptoms or post-hospitalization for COVID. And there is a signal that this may be a risk for CKD, but additional studies are needed to further explore this and to guide whether formal screening recommendations are needed. So now that we've talked about the renal outcomes in those without pre-existing CKD, we'll switch gears and talk about our CKD population and the COVID association with progression. So back to Atiq.
Thanks, Peter. So I'll go over this project again on the kidney disease progression in CKD population. So we wanted to investigate the association between the infection in CKD population and progression to kidney failure. So we did a retrospective cohort study, and we included the non-dialysis dependent CKD patient registered in PROMISE. Our exposure was the RT-PCR confirmed COVID-19 infection, and we took a match study where we matched non-COVID-19 infected controls for each COVID-19 cases. And our outcome was the kidney failure, and we defined it by a composite outcome of sustained decline in eGFR greater than 40% for 4 weeks, or the initiation of maintenance dialysis that sustained for 4 weeks, or incident kidney transplantation. And we will discuss more about the competing event of death. So we used to, with 2 statistical methods, finite grade subdistribution hazard model and cause-specific proportional hazard model. So both these methods are used in accounting for competing event. There are some subtle difference in these methods, how they handle the patients who get the competing event. But I'll just give in short, the finite grade subdistribution hazard model gives us the risk in exposed group relative to the unexposed group, whereas cause-specific proportional model gives us rate of outcome among patients who are alive at any given time point. So analyzing the competing data in both methods gives us understanding of the directionality of the relationship, as well as to check the robustness of the analysis. So we adopted both methods. So this is a bit busy slide, but in short, we started with 22,710 patients. So finally, we had 22,188 patients after the exclusion criteria. BC as a province, we did well. Only 571 patients developed COVID-19 infection. And we had a large pool of 21,600 patients with non-COVID-19 to select non-COVID-19 infected controls. So we used to matching algorithm with large number of variables, including age, sex, EGFR, the USCR, CKD vintage. Those are important for this research question. And our study sample finally had 2,079 patients. So 570 cases and almost 1,509 controls. So at a ratio of 1:3. So I'm not gonna describe this table. This is a large table. We checked all the variables in the matching variables. Most of those are very much comparable among cases and the controls. And further, we investigated a few other variables, co-variables that we thought important in this research question. For example, the cause of CKD, some important comorbidities like hypertension, CVD, and at the end, both the cases and the control groups are highly comparable. So our matching looks like it worked well. This is the outcome distribution. In cases, the proportion of patient with kidney failure outcome was slightly higher compared to the controls. It's 6.3% versus 4.5%. Interesting, the death, the proportion of death was approximately 4 times higher among cases compared to controls. So if the patient experienced death, so they cannot progress to kidney failure. So in this relationship, we had to account death as a competing event. So this is the result from the finite grade distribution that gives us the risk of progressing to kidney failure. So since we have seen here, the proportion of death was much higher in patient cases versus control. So we checked the proportionality hazard assumption and that violated. So we had to estimate the risk over specific time points. So what we see here is the risk of progressing to kidney failure among COVID-19 cases compared to non-COVID-19 controls were higher for the first 4 months. It was much high in the first month, then gradually decreasing. By the 4 months, the relationship was not statistically significant anymore. So then we went ahead with the cause-specific hazard ratio, where we compared the rate, and we exact same finding that the rate of progressing to kidney failure among cases compared to controls were high for the first 4 months. After that, the relationship was not statistically significant. And the hazard ratio estimates were very similar. That gives some confidence about our analysis. So then we stratify, we thought we'll see how if there is a difference in the EGFR for the time period with the short time period we had. So we included the patient with all 3 EGFR measurements in this time period. And since the death rate was higher in cases, we also removed the patients who died and included only those patients who survived for the first 3 months post-COVID, and they had 3 EGFR measurements and in this short period. So what we found was there was no statistically significantly difference between the EGFR decline rate in cases and controls. So our finding is that COVID-19 infection in non-dialysis dependent CKD patient appeared to be associated with increased risk of kidney failure for the first 3 or 4 months immediately after the COVID-19 diagnosis date. And we did not find a difference in EGFR trajectory during this short term of follow-up between cases and controls. So further, we are looking into another work. So it's an extension of this work that we want to take historic cases and controls. Let's say for over a year, both the cases and controls would have very similar decline in EGFR rate. Then a patient gets a COVID here and the bad things happen, the kidney failure or AKI. If we remove this 90 days follow-up data, then we want to see if the cases and controls continue to decline in EGFR in the similar rate, or what happens over the long term. So that's our next project we are working in this field. So Now I'll be talking about the KF40 that Peter mentioned earlier, that if utilizing the KF40 risk equation in vascular access planning gives a better utilization of the vascular access resource. So just a little bit of background. In CKD patient reaching end-stage kidney disease, predicting the time when to create the vascular access is difficult. So in BC, we are recording, currently what we practice is refer patient for vascular access creation when they reach eGFR less than 20 ml per minute, and patient is expected to require dialysis within 12 months. So in previous research reported that this vascular access creation based on eGFR threshold based EGFR-based threshold is poor. So Cunningham published a paper where he reported that 45% of the patient who created fistula or graft did not use that fistula within 1 year of the follow-up period. So KF40, the recent research suggests that KF40 score can play a role in better planning the vascular access creation. So now the question comes is why we are interested in the KF40. So KF40 was first developed by Tangri et al. In 2002, published in JAMA 2021. It's a 4-variable or 8-variable equation that precisely estimate the risk of progressing to kidney failure within 2 years or 5 years. And this risk score is validated extensively worldwide. I believe it's validated in 30 countries in the world. So our hypothesis is that if we use KF40 risk score on the patient assessment date as an adjunct variable with the current eGFR threshold-based referral for vascular access creation, we may have a better utilization of the vascular access services in British Columbia and Canada. So we did a retrospective cohort study. Again, we used data from PROMISE. Our study period was a 10-year period from 2010 until 2020. And we included all the non-dialysis dependent CKD patient registered in PROMISE. They had to be adult patient, 18 years old. eGFR is less than 20. And they chose hemodialysis as their preferred dialysis modality. And the modality selection date was the index date. And on that day, we calculated retrospectively their KF40. So our exposure category had 3 categories. The first one is the current referral that we do in practice. And we use KF40 as an adjunct variable. So that the current eGFR threshold-based referral plus KF40 greater than 40%. This is the 40% published by Cunningham et al. That it was highly precise in predicting dialysis initiation within the follow-up period. And same thing, for a current eGFR threshold-based referral plus KF40 less than 40%. So we had 3 outcomes. One was a primary outcome was the intended appropriate use. We defined this by patient who started hemodialysis, doesn't matter if it is the fistula or graft or CVC within 2 years. And the secondary outcome was a stricter definition of the primary outcome that patient had to start hemodialysis on the fistula or graft within 2 years. And the tertiary outcome was the inadequate use of the fistula and graft created. That means patient fistula graft created, but they did not use within 2 years. So this is the table 1, the patient characteristic one. So first we stratified the study population by outcome. So who started hemodialysis in 2 years versus who did not start hemodialysis in 2 years. If we look into the race, the Caucasian proportion of Caucasians was less in who started hemodialysis in 2 years versus who did not. eGFR less than 20 was a inclusion criteria, so eGFR was appeared to be comparable. However, the USCR among the patient who started hemodialysis within 2 years was substantially higher compared to patient who did not start hemodialysis. As expected, KF40 was much higher among patients who started hemodialysis. and diabetes, both as a comorbidity and a etiology of CKD, proportion were much higher among the starters, hemodialysis starter versus non-starters. So the results here, we are seeing here the primary outcome. That means patient started hemodialysis either on fistula or graft or CVC within 2 years from the index date. So in the overall study sample, compared to the yellow color gives the current referral process, what we do in practice in BC, and the green shows if we had used KFRE greater than 40% as an adjunct variable. And the right-hand side is a subgroup of this population who actually created the AVF and AVG. In both the overall study sample and the subgroup analysis, KFRE, adjunct KFRE appeared to provide better utilization of fistula and graft created compared to the current referral process. Similarly, for the secondary outcome, patient had to start hemodialysis in the fistula or graft. So in this case, I believe the overall cohort had patients who did not create fistula and or graft. So this comparison may not be relevant. So we should look into the right-hand side column where we are seeing patient who created AVF-AVG and started hemodialysis on AVF and AVG. And as hypothesized, the KFRE greater than 40%, the proportion of patient was 9% higher if we had used KFRE as an adjunct variable. And this is the result from our tertiary outcome of inadequate utilization. So same, if we had used KFRE as an adjunct variable, the inadequate use would be much lower in both overall cohort and in the sub cohort who created AVF-AVG. So it looks like if we had used KFRE as a KFRE greater than 40% in predicting the dialysis need within 2 years, the utilization of the AVF and AVG created would be higher in patients in British Columbia. However, if we had the other group, that current eGFR-based referral plus KFRE less than or equal to 40%, how did we do into this group? So out of the total 2,581 patient, the 1,029 patient would have fall into this group, and 368 of this 1,029 patient actually started hemodialysis within 2 years. However, if we had used this as an adjunct variable, this referral could misclassify this 368 patient for not referring for the vascular access creation. So if we calculate this, out of this 2,581 patient, these 368 patient estimate to be around 14%. So there is a chance that this KFRE less than 40% with this eGFR-based threshold may misclassify 14% of the real life patient who started hemodialysis during the follow-up. So we need to do something in here. So our findings suggest that KFRE cutoff of 40% as an adjunct variable with our existing eGFR threshold-based referral has a potential to improve vascular access resource utilization, the fistula and the graft. And we need future prospective research here to validate our study finding and to develop the tools and strategies that will improve the referral for the patient who has KFRE less than 40%. So I'll stop there. And in BC Renal, our research is highly collaborative, and I'm very much thankful to all our research collaborators and the members of our analytic team for their enormous support in conducting all our research.
Thank you, Atiq and Peter, for a bit of a tour de force this morning. Thanks. There are some questions in the chat, which I'm going to, if you want to maybe, one is around the COVID vaccine, whether or not the results apply to people with vasculitis or autoimmune disease. I think that, Cecile, if I understand, like these are people on immunosuppressive agents. So what's the data that we have with vaccine effectiveness on those on immunosuppressives? We have some immunological data in terms of responsiveness, but I don't know that in this cohort of the CKD patients we broke out the autoimmune. Did we, Peter or Atiq?
No.
Yeah.
Yes, of the 518 patients who got COVID, we can look into that, Cecile, but to my knowledge, there wasn't an overwhelming number, but Sean has his hand up. So maybe you can address that, Sean?
Yeah, we haven't looked at that in BC. There are some other, as you said, serologic data in transplant patients suggesting mostly anti-metabolites are associated with poor response as well as rituximab to the vaccine, but that hasn't really been evaluated within BC. As you said, it's a pretty low number because you're starting with a much smaller denominator, and we didn't really get the same number of COVID infections as perhaps other jurisdictions like the United States might have gotten.
Yeah, I think that's an important thing for all of us to remember in the stuff that Atiq presented. Basically, we didn't get the same, although many people did get infected relative to other jurisdictions, perhaps because of the rollout strategy, perhaps because of the public measures, but we didn't get the same onslaught as others. So I think, as Atiq mentioned, it's really important to contextualize vaccine effectiveness within the community that you're in, and it's not a one size fits all or one number of effectiveness fits all. Daniel has a question about the data that suggests that when you create an AV fistula, it slows progression, which is an interesting thing. We didn't look at that specifically that I'm aware of. The question was more about the KFRE. I suppose we could go back and look at that.
Okay. We'll definitely look into that.
Yeah. Sean has his hand up again.
Yeah, Atiq, I wanted to ask you, I mean, thanks for this great presentation. I mean, anyone out there who's not worked with Atiq, he's a really, really smart guy. So he can help out. He's helped me out on a few different projects quite a bit. So anyone who's got any research questions that they're not sure how to answer methodologically, Atiq is a good guy to go to. But Atiq, I was wondering, with your vaccine effectiveness in the CKD population and that paradoxical result of increasing effectiveness with GFR less than 30.
Yeah.
We ran into some questions when we were dealing with the disease flares in the GN population that we published in terms of selection bias for patients who choose to get, a third dose or a booster shot. Are they systematically different than patients who choose not to get that any doses or doses beyond the first or second dose? And so, were you able to tease that out with any kind of sensitivity analyses, like, for example, restricting it to people who got 3 doses, or the self-controlled case series approach that we used previously, to see if that's actually a real effect, or whether it's just confounded by selection bias?
No, we didn't do the further analysis on this. We looked into some variables that why it could happen. So when we looked into the immunosuppressive medication use, what we found, the proportion of patient in this group with higher than 30 ml per minute was double compared to the patient who are on immunosuppressive medication in less than 30. So that could be one of the reasons. The other reason we hypothesized is patient with a higher eGFR than 30 may feel more protected, and their health behavior for taking cautions against COVID-19, contracting COVID-19 infection may be less, whereas patients with less than 30 ml per minute may be monitored more closely and more protected. That could explain a few things, but we did not look it into the analytical methodologically, this thing.
I think our other thought, Sean, was that the people under 30 were probably less well and therefore were less exposed, right? And that might be the other reason that they didn't get infected the same way, that they would be more likely to stay home. But that's a hypothesis. Oh, another question, Anurag. Geographical variations in the risk of progression of CKD after COVID in BC.
I don't think we've specifically looked at that, but we probably could have a look at that and see, you know, in terms of health authority and geographic location in BC for sure.
And I suppose also on etiology, right? So some people, like from the post-COVID clinic data, the diabetics seem to be at higher risk. So we could look by diabetes, non-diabetes, and age. Good suggestions, Anurag. Thank you. Any other questions or thoughts? 2 minutes left. Thank you, everyone, for listening. Over 75 people were here at the peak, and I think that there's a lot of really valuable information, not only about COVID, but also hopefully food for thought with the KFRE and how we might use that and incorporate it a little bit more. But thank you, Peter and Atiq, for all the work that you lead and contribute to, and all the thought that you put into this. So thanks very much, everybody. Happy Friday.
Thank you.